Welcome back to the American College of Surgeons Bulletin Brief from the Frontline Surgeons Voices. I am back with Dr. Frank Opelka, my colleague and our Director of Quality and Healthcare Policy from the college. Last time we touched with Dr. Opelka upon the importance of the ACS quality programs in Washington, D.C., and how we are very well recognized as having reliable, high-fidelity quality programs in place. Dr. Opelka, today I'd like to touch upon with you the next logical set of questions, which is, you and I as colorectal surgeons could think of quality as lack of an anastomotic leak, lack of a thromboembolic event, rapid discharge, however we quantify it. But others think in terms of cost, and they look at value from cost. Could you spend some time explaining how we transition from what surgeons during a morbidity and mortality conference or process improvement conference, how that moves along the spectrum to something that payers and our elected officials understand?
When they think of value, most of them are thinking of the relationship of quality to cost, but cost means different things to different people. And most of our surgeons throughout their entire career have heard from their hospital administrators, you've got to cut costs, you've got to cut costs. And the costs they're talking about are the costs of supplies and of services to deliver quality care. The cost of a fancy Bovie machine versus a basic Bovie that gets the job done. The cost of excessive equipment in the operative field that never gets used, but you always have it available, and so forth. That's cost, but what the payers and the patients and now even the White House and the Congress are talking about is not actually that cost. They're thinking about their cost to purchase care, the price, if you will. So there's a production cost to create the services that we provide. And then there's a price that those services are actually purchased. And there's all sorts of definitions for them. There's gross charges, but nobody pays gross charges. Most of the insurers have a negotiated rate, and that's called the allowable charge. And certainly Medicare does that, and so does Medicaid. And you hope that the allowable charge is actually greater than the production cost. Otherwise, you've got a losing proposition as a company, as an industry. So the president and the Congress are now calling for patients to be able to shop their services, shop and buy, which means they've got to know the price, the allowable price. So we, the college, have been working on two sides of this. One, the cost, the production cost. How do we help a surgeon and their administration look at their production cost? And the other is price. How do we actually define all the services that roll up into a hip replacement, a spine operation, a cardiac case, a colon case, a complex GI case, and so forth? How do we pull all those charges together, those allowable charges, to create what would be the price? If we don't do that, then the patients are going to see this laundry list of allowable charges, much like they see on their current explanation of benefits, their EOBs they get in the mail, and they just toss their hands up and say, I don't even know what all this means. Just tell me what it costs for me to get my care. So what's my price? That's our work. We've worked with Harvard Business School on the cost side, and they've done a fabulous job in creating something called time-driven activity-based costing. And it allows us to determine by the minute who's contributing to the production of a major cancer operation, or the production of a major joint replacement, or a major thyroid operation. And what are all the general categories of supplies, and OR time, and so forth, so that you can, this is not complex calculus. This is stubby pencil math that comes up with what's a relative cost to produce this service, but it's meaningful to a surgeon, to a nurse that's in the room, to pharmacy, to all the team members. They can look at it and it translates into something that's actionable and comparable. I can take one hospital and compare it against another and show you if your resources are more or less than someone else's to deliver a service. So we think that would be extremely helpful to our surgeons who are trying to handle the requests from their administration. Are we overspending? Can we reduce our costs? You know, how can we be smarter about producing our service? On the price side, CMS years ago developed a software system that looks at all the claims data and puts together the price for an episode of care. And they worked with Brandeis University to establish this software. The College of Surgeons, myself included, were part of that software development. The White House and the Congress in the past 2 years has given the College of Surgeons the ability to use this software to analyze claims data and to come up with pricing models. And we've been doing that and have drawn the attention of several of the payers and several of the major ACOs who are trying to figure out their pricing. And it's now starting to catch on as a way of establishing what is the price for a service. So if you, Dr. Wexner, have a procedure and you know your cost and you know your price, you can analyze that and look at it from a value perspective and apply a value judgment. So that's where we are. Does that make sense?
Yeah, it makes perfect sense. It does raise a few questions. The first of which is, how do you account for outcomes within cost? Because if you or I were to perform an anterior section, the patient went home in 3 days without any sequelae, that cost is very different than if the patient develops a leak and needs to go back to the operating room for a stoma or has a percutaneous drainage. How is that information factored in to the equation?
Probably the most important question, and the one that everyone likes to ignore because it's also one of the most difficult. And the payers certainly don't want to go there. So we have actually worked with the software system, and we can risk adjust price. We can use our knowledge of clinical metrics and use our registry data. And with that, we can start to understand high-risk patients, patients who should have an expected incidence of sequela and the cost of those sequela, and give you an expected price for a risk-adjusted pricing model, and then test whether or not your observed meets that expectation. So there are ways to do it, but you're exactly right. And the other danger is, let's take colectomy as an example, the two of us being colorectal surgeons, but colectomy is performed for multiple reasons. Sometimes it's urgent and emergent, sometimes it's elective, sometimes it's cancer, or it's inflammation, or it's an inflammatory bowel case, or diverticulitis, or it's obstructive. There's a whole host of reasons. And when we analyze the data, we find the pricing differences are not just related to the procedure performed, but the diagnosis. So we have to consider both procedure, diagnosis, and add on risk adjustment to establish the expected price. And that's where the work of the college comes in, that this just isn't a math exercise. We have to interface clinical logic into the business logic to come up with what's sensible expectations in pricing.
Is the NISQIP risk calculator a factor in this equation when you're looking at expected outcomes and therefore trying to determine price based on risk adjustment?
So in the initial phases, it's an indirect assistant. It would be our pipe dream, what we often internally tease as cold fusion, to be able to fuse NISQIP directly into fiscal data and map the two of those directly. But instead, we take things like the risk calculator, and it tells us which are the parameters that need to be risk adjusted for, and then we can search for those parameters in the fiscal data. But it's not a direct connect, it's an inference, and it would be much better if it was not just inferential statistics that we're looking at.
Interesting, yeah. So I'm glad I'm thinking on the same lines as you and Cliff. That's encouraging. If I guilt by association, if I can ask you another question. I've heard Dave Hoyt talk about, again, colectomy and actually costing it out. And I don't know if you'd be comfortable reviewing with us, how the calculation was arrived at, because he says it's X amount for operation based upon these things, so your starting point. Maybe you could just, if not colectomy, some other operation, go through an example for us.
So we've been working through multiple different pilots to try and establish the cost side as well as the price side. And Dr. Hoyt's been championing much of the cost work. We've got several pilot sites that we go into those pilot sites and sit down with a surgeon champion, and we define the entire episode of care that we're looking to explore. We've primarily explored cancer, so colon cancers with the exclusion of rectal cancers. And in exploring those, we sit down with the organization and map out from time of initial diagnosis to complete rehabilitated recovery, what are all their steps and who provides those steps. These are long, complex mappings. They're 9, 10, 12 pages long of process maps. And in each one of those process maps, we determine who's providing the service and what's their a minute wage. And so that if they provided 10 minutes at $10 a minute, that's a $100 expenditure for that service. We can then break down the entire pre-op costs, the hospital costs, the post-hospital costs, and provide that pilot site with a mapping that can be compared to other sites who do the same thing. And so that people can look at their population and have a sense of what their production cost would be. And it's been an interesting journey. We're finding out that in certain payer situations, price doesn't necessarily cover cost. And we end up trying to transfer that expenditure onto the commercial sector, which only further inflames the commercial sector about the rising cost of healthcare. So if the government in Medicaid and Medicare, if their pricing doesn't keep up with our cost, and at the same time they keep adding on new regulations which add new costs, then that gets transferred onto the commercial payers' pricing. And there's no wonder we've got such tension in health policy.
Speaking of health policy, the other part of the division, of course, is advocacy. And although this is Patrick Bailey and Christian Chaljan, it's a very direct line, in my view, to what you're talking about, because you're saying that potentially the price paid doesn't match cost and is below, and that's a problem. And yet we're potentially looking at a 9% decrease in remuneration. So as good as the data may be for per minute costs, we may end up being in an even worse situation. And I don't know if you could comment on how we as fellows can help out, if you're comfortable doing so, to try to draw attention to this tension, the word you use, becoming even more tense?
That's a good point. Yeah, our work does provide the foundation for a lot of our policy actions and our advocacy, so that we can be factual in seeking solutions from the government and from the private sector. We also have an increasing number of allies. So Michael Porter's group at Harvard Business School has looked at this as well, and so are many others. The current purchasing system, pricing model system that we have is at least 30, if not 50 years old. And we all know that in our lifetime, care models have changed just astronomically. They're much more complex than they were 30, 50 years ago. So to have as our fiscal backbone, a fiscal architecture that has business logic that doesn't map to the clinical logic, we're going to fail, and we're feeling that failure. So our efforts are to push the Congress and push the regulatory agencies to realize these random cuts that they apply here and there, along with the new required regulations. The new regulations are dealing with the modernization of healthcare. The random cuts are not mapping to those new modernizations. And there's a real need to relook at how we're actually financing, purchasing, and delivering healthcare. Thus, the whole intent of moving to value. That's the opportunity for us to advocate on our behalf. But in the short run, we need an all hands on deck approach to the Congress, to the White House, to the regulators to say, until you've actually really mapped out modern healthcare and priced it appropriately, making these random cuts is actually much more destructive to patient care than you would think. And so we are advocating, and we implore all the surgeons to advocate that for us to deliver the modern care our patients deserve, we really need to rethink the business model in a sustainable way that keeps the surgical workforce going and doesn't rip it apart the way the current fiscal budgeting is doing.
Thank you very much. And I'm glad we're able to end on that point. Christian, Shaljan, Patrick Bailey, your entire division are doing fantastic work in facilitating us as fellows doing exactly what you just said, getting our hands on deck, because it's very simple. Roughly 2 minutes to send the letters to your Congress people and senators, imploring them to please pay attention to this essential issue and not to further inflame and exacerbate an already tense situation. It's always a pleasure speaking with you, Frank. I always get a tremendous education, no matter how many times I hear it. I'm always learning more. Maybe I'm understanding it more. You're dumbing it down for me each time, which is good. I appreciate it. I look forward to our next conversation.
Thanks so much. Appreciate it.